Hello, everyone. It's our big pleasure today to welcome Dr. Ophira Ginsburg for this Queen's Cancer Research Institute seminar series. Dr. Ginsburg does not need probably any introduction, especially for the Queen's family. She has been a member of Queen's family as a medical student and as a faculty in the Department of Oncology before, after which she has also worked at Women's Hospital in Toronto and at IARC Lyon before moving to NYU. As an associate professor, and I recently got to know that she is going back to IARC, International Agency for Research on Cancer, again as a senior visiting scientist. And at that time, I think I tweeted that this is good news for the whole world of global oncology because we need people like Dr. Ginsburg in such positions that can make a difference. And I have personally been privileged to know Dr. Ginsburg not only as a renowned scientist, but also I personally refer to her as my own sister. Her career advice has been very instrumental in my own career growth so far, and I look up to her for advice. So it's my special delight to be able to welcome her back to Queen's for this talk, and I'm very glad that she accepted our invitation. And welcome everyone. I think this is going to be a very exciting talk. She is not only a renowned global oncology scientist, but also she is nowadays inspiring other generation of women in oncology, and recently she gave a very inspiring talk at ESMO annual congress about women in oncology, and I think she's also going to share some of those thoughts with us today. So welcome, Dr. Ginsburg. The platform is yours.
Thank you so much, Vishal, and I also think of you as my brother, my kid brother. Big age gap. It's really my honor to be here today and see all of you. I wish it was in person. I'm just going to, let's see, I'm just going to close this window and get started. The title of the talk is Women, Power, and the Cancer Divide, which I'm sure you might be thinking, what is she getting at exactly? So I'm hoping by the end of the talk, we'll have time for Q&A and get into this a little bit about what we mean by power and how that affects all of us, not just women and women scientists, but men as well, of course. I have nothing to disclose except actually one thing to disclose in the introduction. My first stint at Queen's was in the 80s when I did undergrad at Queen's before doing my master's in genetics and then medical school and then blah, blah, blah. So long history there. So I'm going to start with serious business that many of you might know, but bear with me because I think the story needs to be told in a cohesive fashion. This is data from 2020 from the International Agency for Research on Cancer. I'm sure most of you know is the WHO's cancer agency. And the truth is that just about every minute a woman dies from breast cancer, and every 2 minutes a woman dies from cervical cancer. You know, that's mostly in low and middle income countries. We're talking about almost 700,000 women a year dying of breast cancer, and most of these deaths are premature and preventable. And just to say a quick word about what we mean by premature, in terms of public health and global public health, the World Health Organization defines premature death as being under the age of 70. There is some discussion of extending that, but for many countries, given their life expectancy, that is absolutely premature. And most of these deaths are preventable. And what's worse is with cervical cancer, almost 9 in 10 women who die of cervical cancer are living in a developing country, for want of a better term, low and middle income country. Now, this is a tragedy and it's a travesty. We have the tools, we know what to do. I'm not sure exactly, and I can't see people's faces, of whether they have a little bit of a background in cervical cancer from the public health standpoint, which is an important area of research, as well as practice and policy. But this is really unconscionable. We have almost 350,000 women dying in 2020, and that has long since superseded the numbers of women dying in pregnancy and childbirth. Now, the good news story is a lot fewer women are dying in pregnancy and childbirth, and a lot of that was due to global solidarity, the likes of which we desperately need now on a few domains. And most of these deaths are almost premature as well. And by the numbers, according to IARC, there was 19 million new cases, 10 million deaths in 2020, about 1 in 6 women will develop cancer in their lifetime. 1 in 11 will die. It's not that different than it is for men, although men are more likely to die of cancer than women. I'm hoping that you'll see by the end of this brief presentation is that the impact when a woman dies of cancer actually affects men, people of all genders for that matter, children, and whole societies. Most of these deaths are happening in the global south, and there's going to be a massive increase in the next 20 or 30 years. So just to show you a couple of more maps, you can see the pink here. The pink refers to breast cancer. It's actually Breast Cancer Awareness Month. You might think, what do we need awareness for? Everybody knows about breast cancer, but in fact, in many places of the world, it is absolutely stigmatized. First, you have the sexual organ, the breast, you have a women's health issue, and you also have cancer. So sometimes double and triple stigmas are influencing a woman's agency and actual ability to seek care and then to get the care that they need, even if it is available. And I will bring your attention to one of the studies I've been involved in that sort of humanizes this problem. And we can see here the orange color, if it comes out okay, is cervical cancer, which is still the #1 cancer among women in about 23 countries. And look what happens when I switch to mortality. When we switch, this is age standardized mortality. You see here in North America that the pink has turned to blue. That's a good news, bad news story. The good news is fewer women are dying of breast cancer once they're diagnosed with it. That's generally, the mortality has been declining quite nicely. But lung cancer, of course, continues to be a huge problem among women. And it's not just a problem of cancer of men. We're still seeing great increases in lung cancer rates in other countries as well. And here in the orange, just to show you these 2 or 3 cancers that I happen to be highlighting right now, is that cervical cancer remains the #1 cause of cancer-related death in 41 countries, most of which, as you can see, are in sub-Saharan Africa, but not all. We still have Latin America and some countries in Asia. So I like to go back to one of my heroes, Professor Hans Rosling. For those of you not involved in public health, you might not be aware of who he was. He sadly died actually of pancreatic cancer several years ago. He was a very well beloved professor in Sweden. And his last book, which was on Obama's list of summer reads, I think, perhaps it was the year that Professor Rosling died, was called Factfulness. If you haven't read it, I highly recommend it. And this quote always speaks to me. Factfulness is recognizing that a single perspective can limit your imagination and remembering that it's better to look at problems from many angles to get a more accurate understanding and find practical solutions. And as Professor Rosling says, to control the single perspective instinct, get a toolbox, not a hammer. And that is incredibly important when we're trying to achieve the outcomes that we know should be more equitable across the world for cancer incidence, but moreover cancer morbidity and mortality, is we need to all come together in an interdisciplinary fashion, as we have done for our series, Health, Equity, and Women's Cancers. And as we are going to talk about today, a bit about our new commission called Women and Cancer. The series was a series of articles, primarily review, drawing attention to the epidemiology, the interventions that we know are effective and cost effective, and then a policy paper that was largely, we decided to make it just these 2 cancers because each one of these situations that I've quickly skimmed through here reflect deeply personal stories and deeply profound impacts on society, and in different ways. You'll see in a moment that the commission is much broader than this, and there's a reason for that. The first paper was The Global Burden, with colleagues from IARC and many other colleagues, some of whom I think might have been at Queen's over the years. We see Karen Yates here, of course, and Interventions to Close the Divide, which was again with colleagues at IARC, Lynette Denny, who's sort of like the grandmother of cervical screening in Africa and beyond, and Dr. Shankar, who is one of the best known scientists at IARC, who's still there as a senior advisor from time to time. And the policy paper with Richard Sullivan, who many of you know as a visiting scientist, I believe, at Queen's. And our conclusions were where a woman lives, her socioeconomic, ethnocultural, or migration status should not mean the difference between life and death from these common cancers for which cost-effective life-saving interventions exist. And we talked about the actions that are needed to mitigate cultural and social attitudes that prevent women from presenting with early disease. And I might correct myself here in this wording. In fact, it's presenting and being diagnosed with. We often are told that women present late. Often they actually present early, but there's nobody to see them. There's nobody to make the diagnosis, or they're told you're too young to have this problem. This is not cancer. This we hear again and again. And there's a lot of good research now to estimate the number of months or years it sometimes takes for a woman after she makes some contact with the health system to get her diagnosis and her care. We also talked about embedding a gendered perspective. And I want to just add here that this concept of women and cancer, which is the title of our new commission, is really not meant to be exclusive at all. We're looking at all genders, but there are social aspects of women, of course, that are not unique, but predominantly evident, partly because, sadly, the data that we have tends to be based on biological sex. And that's something that needs to change, of course, understanding that sex and gender are two different things. But I digress. We talked about engagement from political and health leaders, civil society, and global health funders need to come together and need to think of women's health and cancer as a shared agenda. Coming back to that idea of maternal mortality dramatically falling as childhood mortality also fell, and more people came out of extreme societies, were lifted out of extreme poverty as part of the Millennium Development Goals. Wasn't perfect, but a lot did happen. Non-communicable diseases, including cardiovascular disease, diabetes, and cancer, were not even mentioned in the Millennium Development Goals. So that was the starting point for the series. And where have we come since then? So this, I was very proud to say we wanted a female head of state as one of the commentary authors on the series. And we were lucky enough to have then President Michelle Bachelet of Chile, who herself is a physician. She founded UN Women, and she's currently the UN High Commissioner for Human Rights. I had the dubious honor of speaking after her at the ESMO Women for Oncology Forum. But really, I stole this title from her. And I highly recommend you read the short commentary she wrote just a few years ago. So more to the numbers. Gender inequality in cancer among young adults. This is one example of what came from our series. This is a collaboration with my colleagues at IARC, Dr. Salvatore Vaccarella and Dr. Freddie Bray, who's the head of the Global Cancer Surveillance section. We took a look at the adults with cancer under the age of 50 globally and found that in 2020, 2/3 of the 3 million adults diagnosed with cancer at these younger ages were women. We also had an opportunity to study the impact when a child dies, when a mother dies of breast or cervical cancer, what happens to the children? I kind of came up with this phrase of, we've heard so much over the years, quite rightly, about HIV and AIDS orphans, right? That was a big rallying cry in the 1990s, probably before some of you were born, to drive down the costs of medications for AIDS and HIV, et cetera, and get policies in place. But what about cancer orphans, right? So this is a very brilliant young radiation oncologist, Dr. Ray Mayotte, who was a fellow at NYU when I came the first time, actually for my interview before I came to NYU. And he said he'd read the series paper and he was doing his Master's of Public Health the summer before at Harvard and started working on a modeling exercise to estimate child mortality, which was really complicated but fascinating. I got Freddie Bray involved and Sylvia Formenti, who's I'm sure some of you know, was the senior author. This led to, in fact, that paper is cited in the Global Strategy to Eliminate Cervical Cancer because it does at least give an estimate of what the impact might be to whole families. The idea that a child might actually not just live in poverty or be otherwise disadvantaged, but might die if the mother had cancer before that child was 10 years old is something that really hadn't been considered before, not from cancer. It had been considered from HIV/AIDS. This idea then was developed further by Dr. Valerie McCormack at IARC and other colleagues in this sort of seminal piece of work as part of a country, sub-Saharan African prospective cohort of breast cancer once diagnosis has taken place. They're now also trying to look at upstream determinants, but once the diagnosis is in place, they followed women over a number of years. And this is just one of the reports that came out, this one was last year, that noted these are real women and these are real children. For every 100 deaths in this cohort, about half were under 50. And for every 100 deaths in women younger than age 50, there were 210 new maternally orphaned children. And as I'm sure you can imagine, in some situations, maternally orphaned is pretty much the same as orphaned. So I'm telling you all the bad stuff, but I'm hoping will lead to something positive. So, why are these girls and women more likely to develop cancer? So those of you who are epidemiologists or budding epidemiologists will know, of course, the transition from infectious disease primarily to non-communicable diseases. With increasing life expectancy, we're seeing a lot of good things happen. We're also seeing a lot of exposures to those things that we have to contend with and have had to contend with in so-called developed or high-income countries for decades, which is targeted marketing for alcohol, tobacco, poor diet, sedentary lifestyle, and overweight and obesity, which I'll get to in a sec. But keep in mind, how much choice do we really have to avoid all of these products, or to achieve a healthier body weight, or to obtain healthy sources of food that are affordable? I gave away my punchline in a way. I'll come back to it in a sec, but just to remind us, for women, right? Overweight and obesity, we published this in the commentary that I wrote last summer with Richard Horton to launch our Lancet Commission. We took just a quick look at existing data on IARC's website and the attributable fraction of cancer that is associated with overweight and obesity that's now being updated. That was 2012 data. And we found that women were twice as likely as men to have cancers caused or associated with overweight and obesity. So that's one area that's been really underdeveloped because we didn't really look at gender disaggregated data for a lot of these risk factors until recently. So going to hormonal exposures, well, clearly a lot of cancers are hormonally driven, and not just in women, but in women, there's a huge issue regarding breast cancer, especially postmenopausal breast cancer, which is increasing much more rapidly in any country undergoing rapid economic development. And for those of you who aren't aware, some of that is due to lower age of menarche, the first period. Every country, including Canada, right? The first age that I usually ask people to raise their hands, but I can't see. So how old were girls when they had their first period 100 years ago in Canada? About 16, same in the US, the UK, everywhere else. And we see this age come down to about 12 over a very short period of time. That is a significant risk factor, independent of the others. Well, what about the other hormonal factors? As girls are staying in school longer, which we want, as girls are not being forced into child marriage, fantastic. As girls have an option, not in every country, I'm now living in the US, to choose when to have their children, right? To delay childbearing until they finish their education or they develop their careers or whatever their choices might be for them, and to space out their children and everything else, you see fertility rates coming down, right? You see people having fewer children. That's also generally a sign of economic development and women's empowerment for that matter. But all of those things drive the risk of breast cancer. So that's just an example of one such hormonally driven cancer. But what are the other factors that influence cancer risk? And to what degree are these modifiable? And I kind of gave away my punchline earlier. So this is Breast Cancer Awareness Month, and I just saw a tweet from some colleagues of mine at IARC saying, don't smoke, although smoking is not a big risk factor for breast cancer, but of course we say that for so many other reasons. Don't smoke, don't drink too much, stay fit, and maintain a healthy body weight. There you go. Now you know how to prevent breast cancer. But the reality, of course, is like for any other cancer or any other non-communicable diseases, we only have so much agency to do these things, right? Especially when we have changing environments, right? This is an example from Hanoi. I know some of you have probably seen this photo. I love this one. It's near the old campus of the cancer hospital, which is close to downtown. Now they have a fancy new campus. And you can see here, there's this one woman, I don't know how well it shows, but she's looking right at me. She's looking right at the camera. She's the only one with a conical hat, with a bicycle and a simple basket. She's probably finished selling her wares. She probably came in from one of the provinces for the day or a period of time, maybe in between the harvest season from, this is mostly still an agricultural population. And behind her is a sea of motorbikes with men and women wearing masks. This is pre-COVID. Some of them are wearing like scarves because of the pollution. So this is to remind me to say, there's about 10 things in this picture that are worth noting, but I'll just make one comment. Indoor air pollution. This is outdoor pollution, which also is a risk factor for cancer. Sedentary lifestyles, people are trying to get around. Vietnam is a model in terms of economic development in many ways, but we also have the problem in the countryside of people burning solid fuels, which is by far a bigger factor for lung disease, including lung and other cancers in women, because they are the ones predominantly sitting and cooking all day in very rural populations all over the world. And here's another question for you, how much is this preventable and how much is this modifiable? How much agency do we have to make healthy lifestyle choices, as they're called, lifestyle choices? We call them, WHO calls them the commercial determinants of health. And so this is an ad from, I don't know, circa 1980 something. I always forget to put the year, but I mean, check out her hair and the shoulder pads so you get an idea. Virginia Slims remembers what most women's bank accounts looked like in 1957. The implication there is she has to squirrel away the little bit of money she's able to save from a bake sale, or her husband is giving her her allowance or something. And it's not just for white women, right? There's targeted marketing towards African-American, Canadian women from different ethnic groups, that slimness, right, and success and empowerment are associated with tobacco. And this I found quite shocking. I found this online from a WHO meeting from a few years back. If you can't read this, it says no single institution owns the copyright for beauty. And on the right, it says Virginia Slims, find your voice. Right. Alcohol, same thing is happening now. Companies are using images of empowerment and busy professionals to target women. And this was in response to a recent important study, also from colleagues at IARC, Harriet Rumgay and Isabel Soria-Mataram, who is one of the co-chairs for our Lancet Commission, published this important study, and then they broke it down for a bunch of countries. I have this slide that I used at ESMO because we're in France at the moment. 20,000 cases of cancer in France in 2020 that were attributable to alcohol drinking, and this is for both sexes. And look how much breast cancer takes up there. Breast cancer made up more than 1 in 5 of new cases attributable to alcohol. Okay, but men are much more impacted. You can see here on the left panel, 570,000 cases globally caused by alcohol. And for women, only 170,000 cases. So yes, men are much more impacted. And this is a huge problem in men in many countries, not all countries. But take a look at the red square here. What this is indicating is that a full 32%, almost a third of the alcohol attributable cases of cancer in women were associated with moderate drinking. This is really different than for men. The threshold for alcohol to be associated with and ostensibly have some type of causal relationship with carcinogenesis or beyond carcinogenesis to become an actual cancer, this is a very, very low levels of drinking that many people, myself included, do enjoy. So Dr. Soria-Mataram said this highlights the need for the implementation of effective policies. And that's something else I want you to have as a takeaway today. And in the next 10 minutes or so, I just want to draw your attention to some research my colleagues and I did. This is just to show, a tale of two cities. This was probably Toronto. It's a digital mammogram from maybe 10 years ago when I started going to Bangladesh and co-founded a small rural breast clinic that continues now. You can see you have to have an arrow there to see the teeny tiny dot. It's probably a stage 1 hormone positive breast cancer in a 60-year-old woman, the average person who comes into the clinic at Queen's. On the right-hand side, I blacked out some of it, was the least super awful, sad, unfortunate women, super awful, sad, locally advanced breast cancer that was fungating, and something that her family finally abandoned her, or her story might be that she realized that the smell was just too much for anyone at home. I had a woman come in that very first clinic where she literally couldn't move her arm. She had lymph nodes that were completely fixed and matted, and she was in a terrible situation, in desperate need of urgent care, including palliative radiotherapy, which there wasn't available to her. And as Dr. Veronica Van der Poy, who some of you may know from Ghana, who's very well-known clinical oncologist and really a powerhouse in global cancer policy. She's an advisor to the World Health Organization. She's also the other co-chair on our commission. And she says every day she has people come to her clinic, and every now and then she kind of gets mad and says, why did you miss your appointment? Or why did you wait so long to come in? You know this is serious. How come you didn't come? And they remind her, they say, you have to understand me to help me. And so what does that actually mean, right? This is where we worked in rural Bangladesh. We wrote a paper in International Journal of Breast Cancer. There were very few journals publishing this kind of work back in 2012. And this is Heather Story, who led this excellent work that actually she turned into became the foundation for her PhD thesis in anthropology at the University of Arizona, was about how do we improve outcomes from breast cancer in a low-income country, lessons from Bangladesh. And just a snapshot here, we found that in the first 240 cases, only 4% were stage 1 or 2. And that kind of says it all. There was focus group work and semi-quantitative and qualitative research, and these were just some quotes from a focus group about breast cancer. Why didn't you come earlier? They knew they had a problem. They didn't come. It is evil. Once it visits your house, it kills. No one getting cancer gets saved. If you've never met anyone who's survived cancer, why wouldn't you think that? It's actually a very rational thing to think. It's a curse from God, and not to highlight anything about religion and cancer and fatalism that's unique to Bangladesh. Of course it's not. And throughout the world and throughout our country as well, in Canada, many people have ideas about cancer. And it's important to understand what those are. This was one woman telling us, when I said I had breast cancer, he said, I don't want anything to do with you. You can go die. And that was not an isolated incident. And I can tell you, as a former breast medical oncologist whose practice was at Queen's for a couple of years, I did definitely personally see a number of women in my own practice, and those are my colleagues, who had a marital breakdown over cancer for reasons that weren't just about finances, for example, but about the feeling of the woman in their life not being whole. And when we asked women why they didn't seek care earlier, many of them said they had no choice. And the choice made sense to them. They're going to go to the hospital. They're going to spend what little money they have. Their family might abandon them, and they're probably going to die anyway. So why not stay home and do the best you can to care for your family and save the little money to buy the school books for your children? We published this in a bunch of years ago in 2013, when the Journal of Cancer Policy, that was founded by Professor Richard Sullivan, was still new. And I tried to put this in some framing around human rights. And then we had the study with Grand Challenges Canada to try to do something about the situation. And in the interest of time, I think I'll just quickly mention a few points about it. We asked the women, as I just said, what were the reasons you didn't come, et cetera. And then we had some of our colleagues in this region of Bangladesh where we were working ask us, why don't you train community health workers to educate women in the villages about breast cancer? It's a great idea. We built a small clinic and they weren't coming, and maybe this will help reduce some of the stigma. And then we were told by some of the other colleagues, actually women especially, saying, nobody's going to answer the door and talk about breast health. You can't go door to door and do that. But in fact, because our colleagues, all Bangladeshi, we're just a couple of us from the US or Canada, had already developed a real trusting relationship with this community near the clinic because they primarily taught computer skills to impoverished, especially women, but also men and young people. And they had developed this Amader-Graham ITC4D, which means Information Communication Technology for Development program. And Amader-Graham means our villages. They said, let's do this. Let's just try it out. So they went about first speaking with and informing the imams and the other community leaders, religious and otherwise, to get their support, really, to appeal to their concerns regarding their wives, mothers, and daughters. And it was effective. They were speaking to their peers, and there was an understanding that this was something that was important for the community. And so we didn't just come in and do this study. It never would have worked. I can't imagine. There's so many examples of studies like this that actually don't succeed, or they seem to, and then they fall off after the study ends. We did this, here's me and a good friend of mine, Bidan Chandrapal, who's a poet and motivational speaker and a sort of a sociological guy in Bangladesh. And we did this 3 days of training. At first, everyone was shy. Then they kind of perked up when we started making it more interactive. Here, they're learning how to use the mobile phones, because the question was, can mobile phones make the difference? Of course not. But mobile phones were kind of a way to get funding and to maybe something about the phone that would enable the girls, young women really, with high school education, to feel like they could go door to door in their own villages and ask and show a video testimonial on the smartphone. There weren't a lot of smartphones there at the time. Maybe that would also serve to empower the community health workers. And there is some research to suggest that. In any case, we did this door-to-door intervention. It was a randomized controlled trial where 2 groups of community health workers had the phone with the video, and one had paper and pen, because it's worthwhile seeing, does it really make a difference? Is it more or less efficient to have the phone or not have the phone and all this? And one of the 2 groups, the community health workers with phones, also had a half day of patient navigation training, which I must admit, I did not develop rigorously. I kind of developed it in the car on the way to the rural area a few days before, based on my limited understanding at the time of what patient navigation could be. But among our team members were people who really understood the cultural issues. We even had somebody who served as a counselor for the cancer patients shortly after that study got underway. And they helped us out with this concept of asking good questions to draw women out. So when you ask them, look, you have a breast lump, you let us examine you. Thank you. Yes, you have a breast lump. You're right. You need to come to the clinic. Will you come? And they're all going to say yes. So, but most of them won't come, because that's the nature of the situation in many such places. So we offered them extra discussion, including whether they want the community health workers, the women, to come back with a male colleague and talk to the father or father-in-law or husband. It was even sometimes a matter of helping with childcare, basic things to help what we consider patient navigation in Kingston, for example, same kind of principles. Ultimately, 4 months, 30 community health workers interviewed 22,000 women. It was a great success. Very few declined participation. More than 500 women did have an abnormal exam, and the adherence coming to the clinic improved by 50% if they were interviewed by a community health worker with a smartphone that had patient navigation training. So that was a big lesson for a lot of us, including myself, of course, in the value of really women's empowerment over and above the mobile phone, I must say. And this leads us to the last few slides on the Lancet Commission on Women in Cancer, where we are in the process of hopefully addressing the urgent questions at this intersection of social inequality, cancer risk and outcomes, and the status of women in society. And this came out, this was a blog that I wrote that came out the day of the ESMO Women for Oncology Congress 2 weeks ago. And we talked about the intersection spanning broad terrain. It encompasses wide-ranging impacts, including the influence of gender on exposure to cancer risk factors, the biomedical aspects that you all know well as the indirect effects of cancer on the psychological, emotional, social, and economic health and well-being. And the latter extends to children, families, and societies. We're also going to address the obvious real gender inequities experienced by what is predominantly a female healthcare workforce. One thing I didn't mention about the community health workers in the segment we just finished talking about was that these CHWs were paid. We decided to pay them because in Bangladesh, they're paid reasonable wages by the government, but in many places in the world, they're not paid. They're volunteers or they work off of incentives. And however you slice it, they are undervalued and under-recognized, and they're predominantly women. So our vision for the Commission is a world where every person, regardless of gender, geography, economic status, or identity, can realize their right to accessible, affordable, and quality cancer prevention and care. And our mandate is to take an intersectional feminist approach to cancer, which is something that's new and novel. We have an anthropologist on our team. We have a sociologist. We have about half of our commissioners, 21 commissioners, with 3 of us being chairs, who about half are not cancer experts. In fact, they're health systems experts. They're gender scholars, as I mentioned, social scientists, including one anthropologist. And some of you actually know who that is, Carlo Kadov. And we have a number of advisors as well. So we're trying to really break the mold here, do something different and transformative. We're going to look at the preventable burden of cancer in women, of course, the epidemiology. That's why I'm here at IARC right now, working with the cancer surveillance section that's hosting me. We're going to apply more inclusive economics analysis that takes into account the factors that I mentioned and the downstream impacts, maybe making an investment case if we're lucky and we can get to the point of actually making that kind of investment case for tackling women's cancers, where you have a return on investment that goes far beyond just saving the one life, as if that isn't important enough, right? Some call this a feminist economics, and that's being led by Rachel Nugent, who's been on half a dozen or a dozen Lancet commissions and led the Lancet Non-Communicable Disease, NCD's economics task force. So we're really lucky to have her on the team. We're going to take stock of the missing women leaders in oncology. And I say this understanding that at present, ASCO, ESMO, and AACR are all led by women. But in general, and until recently, this was not the case. And we don't want this to be the exception. There certainly are women who can achieve great things in oncology, and we have examples in Kingston and Queens, of course, Dr. Elizabeth Eisenhower, one of my beloved, Dr. Eisenhower, beloved mentors. But in fact, in many countries of the world, we see women who have had enough training to be able to move up the ranks academically or in their own hospitals, and they just don't even have a chance. The ground is not even, and there has to be a lot more done to support women in the future. So the commission is actually not just going to be a report, and we can talk in the Q&A, what is a commission and what are the outputs? We're trying to make this a living enterprise, which will include some fundraising opportunities for scholarships for young women in oncology in developing countries. And about half our commissioners actually are from a lower middle income country. The other half largely were from an LMIC and moved to a high-income country. I'm going to end with 2 quotes. One is Professor Mary Beard, who I only recently learned about, who's actually a professor of Roman history, but also a feminist scholar. And this is a book from 2017, Women and Power, a Manifesto. She said, you can't easily fit women into a structure that's already coded as male. You have to change the structure. That means thinking about power differently. It means decoupling it from public prestige. It means thinking collaboratively about the power of followers and not just leaders. And it means thinking about power as an attribute or even a verb and not a possession. And the last quote by Professor Angela Davis, who's still a professor in California. She was a major civil rights and feminist activist in the 60s. And this is my favorite quote of all time. I'm no longer accepting the things I cannot change. I'm changing the things I cannot accept. And I'll end with a slide that has not enough people. I should have a lot of people at Queens who helped support me over the years. But these are our commissioners of the Lancet Commission on the left, our advisors here, you'll recognize some names, our collaborators, growing list of collaborators, and our partners, and including the Lancet, of course. And to thank all the women everywhere who generously participate in cancer research. Thanks for your attention.
Wow, that was quite a talk. Thank you very much. It was very inspiring, very uplifting. And I'm pretty sure our audience have learned a lot today. And it was like quite appropriate in length as well, so that we have enough time for questions and answers. So I'd like to ask if anyone has any questions.